I want to thank everyone for joining us here this evening. Super excited about our presentation by Dr. Jolie Rodman and coming from Wu University. And tonight's presentation is Common Retinal Conditions. The next slide. I'm your host, Dr. Carolyn Major at Northeastern State University. And we want to give a special shout out to our sponsor. And without sponsorship, we wouldn't have free CE opportunities available to you through Wu University. So I want to give a special thank you to Astellas for exhibiting at this event. And at this time, we're going to take a moment just to complete the poll survey that pops up here. Next slide. And just some friendly reminders before we get started with tonight's exciting program. So for each hour of CE units, attendees must be online for a minimum of 50 minutes. And for COPE certification, you need to fill out the survey link that's going to be in the chat box. That's not the poll questions. There's a separate survey in the chat box here that you need to take both before and after the presentation to receive CE credit. And so that survey link is going to pop up again once you close the Zoom webinar, once the program ends. And it's also going to be posted again in the chat box at the end of this program. CE certificates will be delivered by email and sent to ARBO with OE tracker numbers. We're also going to have a QR code at the end of the event that if you have the OE tracker app, you can't just use your camera. It has to be using the OE tracker app on your phone. You can snap that as well. CE certificates will be emailed within 4 weeks after today's presentation. And please ask questions throughout the program. We're going to have a live Q&A here with Dr. Rodman at the end. So feel free to ask questions using the on-screen floating panel down below if you're tuning in from your laptop. Next slide. And if you're attending using your phone, you can also enter questions using that little Q&A box up at the top or the 3 little dots at the bottom of your phone screen there in the bottom right-hand corner. Next slide. And so it was with great pleasure that I introduce here this evening a dear friend and colleague, Dr. Jolie Rodman. We're so fortunate to have you, expert retinal speaker and educator. So Dr. Jolie Rodman is chief of the Broward Eye Care Institute in Fort Lauderdale, Florida, and is a professor of optometry at Nova Southeastern University. She's also the instructor of record for posterior segment disease at the school, and her research interests, similar to mine, include OCT and OCT angiography and vitreoretinal disease. Dr. Rodman has authored over 30 publications with an emphasis on retinal disease, and she recently published Optical Coherence Tomography Atlas, a case study approach, the first reference book on this topic written by an optometrist. Dr. Rodman is a member of the AOA, AAO, FOA, and ORS. She's been the recipient of numerous teaching awards, was recognized as Primary Care Optometry News Top 300 Optometrists and Newsweek Best Optometrist of 2022. And without further ado, I'm going to turn it on over to you, Dr. Rodman.
Thank you so much, Dr. Major. It's truly a pleasure to be with you all tonight. I know that this lecture was called Common Retinal Conditions, but I kind of labeled it something that I thought was more appropriate. Top 5, what you will encounter in your retina practice. So what I was hoping to do tonight, there's a lot of content, but I was hoping to go through some things that I know every single one of us is seeing on a daily basis and just give kind of a quick synopsis of these entities. So I'm going to start off with one of my favorite things to see and diagnose and take care of, age-related macular degeneration. So starting off with some statistics and some just general information about the disease, AMD is a significant cause of blindness worldwide and really is the third leading cause of visual impairment globally. It accounts for 9% of blindness worldwide, which is about 200 million people. So really, this slide talks to the importance of diagnosing this condition in a timely fashion so we can really lessen the terrible visual sequelae of this disease. So we know here, let me just get rid of this here. We know that when we're talking about age-related macular degeneration, it's very important that we don't tell everybody the same diagnosis. AMD is not all created equal. We know that there are mild stages, there are intermediate stages, and we know that there are advanced stages, which are made up of geographic atrophy and and neovascular AMD. What I like to tell my retina students is anytime you're learning about any retinal condition, you have to go back to retinal anatomy. You have to understand what part of the retina different diseases affect. So when we talk about AMD, we're essentially looking at or talking about conditions that affect that horizontal dotted line and below. So photoreceptors, RPE, Brooks membrane choroid. This is kind of going to be the hot spot here of where age-related macular degeneration affects or occurs. On OCT, and those of you that know me know that I love OCT, we're going to be really focusing on where this black arrow is. So this first hyperreflective line here is our photoreceptors. We have our RPE, which is this thick wedge right underneath it. Brooks membrane kind of hides out, and then the choriocapillaris. So again, this is going to be the area of emphasis when you're trying to find AMD, classify AMD, diagnose AMD. Really, the hallmark behind this disease, the thing that is the domino that leads to the bad sequelae, is drusen. Drusen, we know, are a retinal waste product. We know that they live between the RPE and Brooks membrane. So looking for these drusenoid deposits is really going to be how we're going to start to categorize and identify this disease. These deposits, these waste products are going to lead to damage of the photoreceptors, of RPE, of Brooks membrane, of the choriocapillaris. On OCT, remember I just said that drusen live between the RPE, which is this hyperreflective area here, and Brooks membrane. So these homogeneous areas here are our drusenoid deposits. And we want to pay specific attention in AMD to the size of these deposits because that's going to help us to classify or categorize the disease. So when we look at risk factors for AMD, it's kind of interesting when you think about this. There are so many things that come into play when you're trying to tell a patient if they're at risk for developing this disease. But 70% of the risk of this disease is actually genetic, which we know is out of our hands. If you're born into a family with a high genetic predisposition, you're already behind the eight ball, right? Because that's 70% of the contribution. The other 30% is made up of physiology, lifestyle, and environmental factors. So age, as the name implies, age is the greatest risk factor in this category. Obesity, certain dyslipidemias like high cholesterol, cardiovascular diseases, high blood pressure, smoking, diet. Remember that smoking is the #1 modifiable risk factor. These patients not only develop disease earlier, but they develop disease at a much more advanced rate. So looking at all of these things in combination are going to help us to determine which patients are more at risk for developing this disease than others. The pathophysiology, as I mentioned before, really revolves around the outer retina and the deposition of these drusenoid deposits. So when you look at a healthy retina, and this is a really pretty slide that was given to me by my friends at Maculogics, it's a really nice slide of a healthy outer retinal anatomy. Here we have our photoreceptors, RPE, Brooks membrane, choriocapillaris. And when everything's functioning properly, the choriocapillaris can supply nutrients to the layers above, and everything is healthy and well fed. And obviously at this point, we're not going to see anything fundoscopically. AMD really begins, though, with what we call this cholesterol slick or this cholesterol barrier that begins to form along Brooks membrane and is going to eventually settle between the RPE and Brooks membrane. When you have this cholesterol barrier, think about how difficult it is for the nutrients in the choriocapillaris to get over Brooks membrane into the RPE and photoreceptors to provide the nutrition that they need. So this initial cholesterol, which is going to eventually turn into drusen, is really the kind of the impetus or the starting factor behind this disease. The scary part is that fundoscopically, we cannot see these very early signs of cholesterol buildup. So there's things happening behind the scenes in this disease, which is why it's so important to discuss risk factors before we see clinical manifestations that we can avoid or try not avoid, but help to slow down the progression or the growth of this cholesterol deposition. As the disease progresses, you can see here that this cholesterol slick is really beginning to grow. It's becoming, much more apparent. And look at how sick the overlying RPE is. Look at how sick, you can't really see the photoreceptors. I'll show you on the next slide, but the outer retinal tissue is not getting the nutrition. It's not getting the vitamin A. It's not getting anything from the choriocapillaris that it needs. So everything is dying above. But really scary thought, nothing is going to show clinically at this point. Again, emphasizing the importance of smoking cessation, good diet, cardiovascular health, exercising, taking good care of yourself. Once you have enough of this cholesterol buildup to lift up the RPE, we now see a drusen. So this is a clinically a drusen formation. And what you'll notice here is that the photoreceptors are like skeletons, right? Everything is essentially dying here. Nothing is getting the nutrition that it needs. And this is where you're going to actually see drusen fundoscopically. So it's not until you have enough of that cholesterol buildup, they're actually going to get drusen deposits. So just kind of this cascade here, really exemplifying that drusen and what it does, the damage that it does to the outer retinal tissue. I started off this section by telling you that not all AMD is created equal. The Beckman scale is really the most commonly accepted or widely accepted classification scale that we have for AMD. I'm going to go through it pretty quickly, but remember that we don't want to tell everybody that has drusen that they have AMD. So if patients have very small drusen, which we define as less than or equal to 63 microns, that's okay. They're allowed to have some small drusen and not have AMD. Once the drusen grow, once they begin to be about 63 to 125 microns, that is essentially early AMD. And you'll be able to see, as you're seeing more and more patients with AMD, what these drusen look like, and as they grow, what category they're in. There should not be any pigmentary changes in the early stage, because that is an indication that RP is dying or dispersing to the upper retinal space. In the intermediate stage, you have to have at least one large drusen. So if you look at the vein, the central retinal vein as it leaves the optic nerve head, that width or that caliber is about 125 microns. So what I like to say is if you have a drusen that's around that size, then we're essentially into that intermediate category. Or you can have pigmentary changes. That is an indication that the RP is not doing well and it's dispersing or breaking apart. We know that the advanced form, there's a dry geographic atrophy and wet categorized by neovascular or choroidal neovascular membranes. Use multimodal imaging when making the diagnosis. It's very important to look carefully for those undulations or those, elevations of the RPE, which is essentially drusen. And what you'll note as we go through these from no AMD to intermediate, the drusen are going to become larger. We can essentially call these drusenoid pigment epithelial detachments because they're big enough that they're lifting up the RPE. You can see this hyperreflective area here, which is that pigmentary disturbance that I talked about before. So kind of pay attention to the drusen on the OCT when you're first learning, or actually as you're becoming a pro, to try to differentiate the different stages of the disease. Fundus autofluorescence is also extremely helpful. We know that in a normal retina, anything black has no lipofuscin and should not fluoresce. As this disease progresses, you'll begin to see differing fluorescent levels depending on whether there's drusen or atrophy there. So look again at FAF for clues as to the stage of the disease. Advanced AMD, geographic atrophy, and choroidal neovascular membrane. And just a quick, review of wet AMD treatments. So for patients that have choroidal neovascularization, really the most widely utilized treatment is anti-VEGF. Laser treatment is sometimes used, and photodynamic therapy or PDT is another option. I wanted to just give a quick shout out to geographic atrophy because it's been quite a year. For the first time, we have a treatment for GA, which we've never had before. I'm not going to go over this again, but I talked about how advanced forms of disease really lead to this loss or irreversible changes in the outer retinal tissue. Geographic atrophy doesn't have to affect the fovea. In fact, it usually begins parafoveally, and as it migrates more towards the fovea, that's when patients begin to actually notice scotomas and decreased vision. So when you look at these big cities, they actually have about the same number of people in them as geographic atrophy, which actually is 1.5 million people. So this is a crazy prevalent disease, thus really reiterating the importance of diagnosing it. Just to really quickly kind of highlight the use of multimodal imaging, regardless of what you have in your practice, whether it's color fundus photography, fundus autofluorescence, fluorescein, OCT on-phos, OCT-B scans, near infrared, anything you have, become a pro at it, learn how to look for geographic atrophy, Be familiar with things like hypofluorescence, with choroidal hypertransmission. These are some of the common things that we want optometrists to be familiar with on a day-to-day basis. And really, the important thing now with geographic atrophy is as early as you see it, we should be referring. In the good old days, we had nothing to do for these patients except lifestyle modification, which, as we know, has really not been extremely efficacious. Patients are progressing and advancing at a very rapid rate. Now we have two treatments, Syfovre and Izervay, which are intravitreal complement inhibitors. Important to note that these do not get rid of disease, but they actually slow down the progression of the disease state. So please, take an interest in looking for GA. Happy to help anyone that wants to learn how to use multimodal imaging, but very important that we identify it early so that we can give the best outcome to the patient. Identify early, refer soon, and slow the course of the disease. Okay, I'm going to move pretty quickly through this because I have a lot of content and I want to try to get to everything. But the next topic is going to be diabetic retinopathy. So 38.4 million people in the United States have diabetes, which is about 12% of the population. Diabetic retinopathy affects about 30% of adults with diabetes and is the leading cause of blindness in working-aged Americans. So these are, again, things we're seeing every single day and have terrible visual sequelae, could have terrible visual sequelae for the patients. For risk factors for diabetes, there's a lot of them, but the really important ones, the ones that really have been shown to have the strongest correlation with the development of diabetic retinopathy is the duration of diabetes and blood sugar control. When the students come in to present these cases for me, I tell them that these are questions that we need to ask every single patient. I don't want to just know that the patient has diabetes. I want to know how long they've had it, and then their HbA1c and their blood sugar. Most of the time they don't know it, but we at least need to ask. And then other risk factors, blood pressure, smoking, race, pregnancy, obesity, some other medications they might be taking or medical conditions, family history, and again, genetics. And what you'll notice here is there's a lot of crossover in these diseases, something like AMD and diabetic retinopathy, a lot of crossover in some of these risk factors. So just like we went through staging of AMD, it's important to remember staging DR. This is going to be easy, so we'll go through this quickly, but we know there's three main categories: NPDR, PDR, and then diabetic macular edema that can happen in any stage of the disease. So when we look at the AOA guidelines, this is essentially the definition: mild PDR categorized by just microaneurysms. Moderate falls somewhere between mild and severe. And we know that severe is the 4-2-1 rule. So we're looking for 4 quadrants of retinal hemorrhages, 2 quadrants of venous beading, 1 quadrant of IRMA. And then very severe is when you have 2 of the 4-2-1 category. And why do we care about this? Why is it so important to classify it correctly? Because patients that have severe disease have a greater than 50% risk of developing PDR in 1 year. So that's huge, right? We want to be able to identify these patients properly to try to intervene at an appropriate time so they don't go on to develop proliferative disease. Eyes with very severe, so remember 2 of the 4-2-1 rule, have an over 75% risk of developing PDR in a year. So really crazy numbers. So, looking at history, when should we see these patients back? Mild NPDR, it's appropriate to see them in a year. They only have about a 5% risk of progressing to PDR within the year. Moderate, I would say 3 to 6 months. Remember that moderate is kind of a shady category. There's a lot of differing presentations of moderate, so that's going to depend a lot on the patient and everything they come with. These patients have about a 27% risk of developing PDR within the year. And then severe, these I would co-manage with retina. These patients have up to a 50%, as I mentioned before, chance of progressing. And these are just some pictures, which I'll fly through pretty quickly. Mild, you can see a couple of MAs kind of floating around here. Moderate, remember, we're looking for more than microaneurysms. So once you have dot blood hemorrhages, exudates, continental spots. Severe, we're looking for IRMA, we're looking for venous beading. These are just some really pretty pictures of severe. Remember, we're looking for 4 quadrants of retinal hemorrhages, 2 venous beading, 1 IRMA. So just some nice examples there. And then when we get in the PDR category, we know that that's NVD or NVE. And then there's high risk categories as well. NVD greater than 1/4 to 1/3 of the disc area. NVD that's associated with a vitreous or preretinal hemorrhage. and NVE that's associated with a vitreous or preretinal hemorrhage. And it's a lot to remember. So to be honest, a lot of this stuff, we go back and look at, but it's good to have to be familiar with it once more. Here's some pictures of proliferative disease. We all know this when we see neovascularization of the disc, when we see any vitreous or preretinal hemorrhage, neovascularization elsewhere. And then here are just some pictures of high-risk categories, or the high-risk pictures. This is a beautiful picture of neovascularization of the disc. And I wanted to add this photo because, at quick glance, it looks pretty clean. But when you look at it very closely, hopefully you can appreciate that there's some anomalous vasculature really yelling to the fact that we need to be super careful with these patients. Sometimes the eyes look so clean that they're actually ischemic, and it's easy to miss some of this proliferative disease. Patients that have any proliferative disease need to be sent to retina. If it's just regular PDR, I would say within 1 week is appropriate. If it's high risk, within 1 to 2 days. And obviously, if the patient has a tractional retinal detachment, we want to refer stat. Remember that diabetic macular edema can happen in any stage of the disease. That's when we get fluid accumulation within the retina that forms, intraretinal cystic spaces. And this is really one of the biggest reasons that patients lose vision. So in the good old days, we loved the word clinic, or the term clinically significant macular edema, because these patients, really were defined as patients that were going to go on to lose vision at a significant rate. And I always found it so difficult clinically to remember. I hate to memorize definitions. So I always found it so hard to remember all these definitions. So the good news now, instead of me sitting and reading all of this, is that if you own an OCT, there's actually an easy way. And these new terms are totally OCT based, but you don't have to memorize them, and they're much easier to clinically work with. So when you have diabetic macular edema and you're using OCT, you can look at 2 terms, center or non-center involving DME. And what we're looking at essentially here is how close to the macula, how close to the fovea is the diabetic macular edema. So using this ETDRS grid, you're essentially looking at the center 1 millimeter subfield. If that center 1 millimeter subfield is abnormal, then that would be considered center involving. And if it's normal, falling within the normative database, it's non-center involving. It's much, much easier to really look at that and get those scans. It's an objective measurement and a way of assessing these patients. Eyes with center involving DME have a much greater chance of developing moderate vision loss, so these patients need to be managed in a much more aggressive manner. So this is just an example of how I would work through one of these patients. If you had a patient like this, you can see that there's bleeding and exudation within the macular area. So the first thing you want to do is get an OCT to even see if there's DME. You can see here that this patient does have DME. So the next step would be to get your ETDRS thickness map, and you'd be looking at that center 1 millimeter subfield. You can see that this patient has a very heavy or very abnormal center 1 millimeter subfield. So this patient has center involving DME. Similarly, or I should say not similarly, here's another patient that has fluid. You can see that this patient's fluid is not close to the fovea, which is substantiated on this retinal thickness map. So this one would be non-center involving DME. So really the way you want to do this is identify that there's actually stuff happening near the macula, get your B scan, and then get your thickness map. And here's another example, again, just of a patient that you get your B scan, you identify that there's abnormality, get your thickness map, and you can see that it is center involving. So some pearls, remember that you can refer DME at any stage. You should consider it. If patients have non-center involving DME, you could probably hold on to it a little bit longer. The AOA practice guidelines tell us that we should refer center involving DME within 2 to 4 weeks. Just to get really quickly to familiarize you with something called Protocol V. We have patients often that have center involving DME that have good vision, meaning they have better than 20/25 or 20/30 vision. And we refer them, which is totally fine. But what we find a lot based on this protocol is that a lot of retina specialists are not doing anything with patients that have very good visual acuity with CIDME. So if you have a patient that has very good visual acuity with CIDME, you can probably hold on to it if the vision's really good, because a lot of retina specialists most are not doing anything with this visual acuity. So that's just kind of a shout out there to a management option that you may have. If the patient does have worse than 20/30, you're absolutely going to refer it within 2 to 4 weeks for intervention. And we know this, I will skip over this, but the anti-VEGF drugs that are used for DME, these are just a bunch of the choices that are out there. Okay, the next entity we're going to jump into is retinal vein occlusions. So retinal vein occlusion is super important because it is the second most prevalent retinal vascular disease right after diabetes. The thing with retinal vascular occlusions is they're highly associated with systemic disease. Patients get this entity when they're not healthy. Morbidity and mortality are highly associated with retinal vein occlusions. The two main risk factors, getting older and systemic vascular disease. When we talk about vein occlusions, we talk about two things, the site of the occlusion and the amount of ischemia. So if the central retinal vein is occluded, then it's a CRVO. If a branch retinal vein is occluded, it's a BRVO. If half of the central retinal drainage is occluded, we call it an HRVO. And then again, we look at the amount of ischemia. When we look at pathophysiology of this disease, it's actually interesting. This schematic here, this image shows you that the central retinal artery and the central retinal vein actually intertwine around each other within the lamina of the optic nerve head. So if there's atherosclerosis of the central retinal artery, that's actually going to impinge upon the central retinal vein and cause a thrombosis or a clot within that area where they bifurcate or where they intertwine. So it's actually a disease where we look at the neighboring central retinal artery to understand the pathophysiology. When we look at systemic reasons, remember I mentioned before that patients that are not well get this disease. So uncontrolled high blood pressure, diabetes, cholesterol, heart disease, the hyperviscosity syndromes, any inflammation of the retinal blood vessel in the form of sarcoid, syphilis, lupus, COVID, huge one right now, miscellaneous things like drugs, oral contraceptives, migraine headaches. And remember that if patients present with kind of anomalous findings like bilateral disease, or if they're very young, then we need to kind of look out of the box. For ocular etiologies, we're looking at things that cause increased pressure within the stalk of the optic nerve head. So things like ocular hypertension and glaucoma are going to be the most common reason. Other things would be disc edema, drusen, orbital tumors, cavernous sinus thrombosis, thyroid eye disease. Instead of memorizing this, think about anything that causes compression within the stalk of the optic nerve head. We know about symptoms of progressive painless loss of vision. That's going to depend on, or the extent is going to depend on what type of occlusion it was. You know, if it's a CRVO, the patient's going to have much more vision loss than a BRVO. This is really straightforward. Think about the central retinal vein draining everything in the retina. So if the central retinal vein is not draining properly, you're going to get a backflow everywhere. That's why you get 4 quadrants of retinal hemorrhages, 4 quadrants or garbage everywhere, right? A backflow of the drainage pump. So everywhere on the retina is going to be affected. And the retinal veins are going to be dilated and tortuous because remember that we're not getting the drainage out of them. So they're getting congested. Later in the disease, patients can get collateralization, which is really where a pre-existing blood channel develops or fills up, I should say, in response to this lack of drainage. So you'll see them on the nerve usually. This is where the site of occlusion usually happens. They can get disc edema. Neovascularization is not quite common, but can happen more commonly in the anterior part of the eye in CRVOs. That's because it's directly correlated to the amount of ischemia. The more ischemia, the more VEGF is released. So if there's more VEGF released, there's a bigger propensity that it can reach the front portion of the eye. Patients can get vitreous hemorrhage, neovascular glaucoma. Remember that CRVO is called the 90-day glaucoma, right? These are patients we want to watch very closely for the development of neovascularization. If the patient had an ischemic event, 60% of them get neovascular disease. So be really, really careful those first 3 months after diagnosis to do gonioscopy, check that iris collarette, and make sure you're looking carefully for the development of neovascular disease. HRVO similarly, but you're only going to get remember, this is half of the drainage of the central retinal vein. So remember that in HRVO, the distribution is going to be both nasally and temporally. That's how you're going to differentiate it from a BRVO. You can also get collateralization here as well. You can also get neo, but an HRVO, because it's not as ischemic, the retina is more likely to be affected than the front part of the eye. Vitreous hemorrhage and neovascular glaucoma can happen more commonly, again, in ischemic situations. BRVO, we know it's one branch retinal vein. And the cool thing about BRVOs is that you can actually see the bifurcation, and you can see that backflow right where that bifurcation happened, right where that crossing change happened. And you're going to see one isolated dilated retinal tortuous vein where that damage occurred. Collaterals could also form in BRVOs, usually between the vein that is not functioning properly and a viable vein. It's usually between two retinal veins. And you can get these other later findings as well, not as commonly because BRVOs will not result in as much ischemia. Remember to use OCT scans to always assess for macular edema with retinal vein occlusions, because this is going to be a referral, right? If the patient has macular edema, we're going to refer it. Keep in mind that when patients have vascular occlusive disease, the number one thing you want to make sure of is that you're taking care of them systemically, because that's the reason that this happened. Also important, obviously, to look for macular edema and neovascularization, but make sure you're taking care of the patient's systemic condition as well. These are just some cool pictures of OCTAs of patients that have vascular occlusions, showing these really distinct areas of capillary non-perfusion due to chronic disease. So here's the management once again. Make sure you're doing you're ordering the appropriate lab work. You're reducing intraocular pressure, since remember that glaucoma and ocular hypertension are big risk factors. And you guys have these slides on you, but these are really nice things to go back and look at when you're trying to make an appropriate referral, so that you know what tests to order. And remember that if they do have macular edema, they have to be referred out. The studies have told us that the earlier that we send out, the better outcome the patient's going to have. Choices include anti-VEGF, intravitreal corticosteroids, laser, and if the patient does have neo, usually they do PRP with an anti-VEGF. So this is the clinical pearl that I alluded to before. Remember that in order to keep the patient alive so that we see them every single year, we need to address their systemic condition. Make sure that, yes, this is affecting the eye, but make sure that we're working and co-managing this with their internist to get to the bottom or the root cause. Okay, this moves us into the next entity, peripheral retinal disease, which will touch on a couple things, but retinal detachment to start. We know that retinal detachment falls into three main kind of trees. We have rhegmatogenous, which includes a retinal break or tear, tractional, which is due to something like diabetes, sickle cell disease, anywhere you have a proliferative process, and serous detachments where you have heavy exudation. Maybe you have a tumor, something that's causing buildup in that subretinal space. Because rhegmatogenous is probably the most common of these, that's what I'm going to talk about. Retinal detachment happens from rhegmatogenous causes in about 1 in 10,000 patients. We know risk factors: lattice, peripheral retinal breaks, high myopes, previous intraocular surgeries, traumas, previous RDs, or if you have a family history. Not all RDs are created equal. Remember that when you look at a patient, you got to check and see if the macula is involved or not. So here's a really nice picture of a patient that has a macula on RD versus this patient who has a macula off RD. And it's super important to categorize it properly, because the management is going to differ. This is a mystery case. So what if you see a patient that looks like this and you're just not sure? Use multimodal imaging. So here are two OCT images of patients that have retinal detachments. What you'll notice on this image, the colored image, is that, remember, the definition of a retinal detachment is a separation of the neurosensory retina from the underlying RPE. So here you can see that the macula is completely off. This part of the neurosensory retina is completely separated from the underlying RPE. This one, the retinal detachment, is out here. So this is a MAC on. So if you're not sure, if you have a case where it's not clear to you, get an OCT, especially if it's close to that macula area. And here's just some OCT-B scans or showing what RDs might look like. So for management, if you have a macula off RD, refer as soon as possible, usually within 48 to 72 hours. The earlier you get the patient to the retina specialist, the better the outcome is going to be. If the patient has a MAC on retinal detachment, it's an immediate referral. For those of you that have called up your local retina specialist and told them you have an RD sitting in your chair, the first thing they're going to say to you is it a MAC on or MAC off RD? Because it's going to make a big difference in how urgently we have to get the patient to the retina specialist. Some treatments include laser, cryo, which is when they use some freezing therapy, some different surgeries, sclerobuckle, vitrectomies, pneumatic retinopexy, topical meds, and silicone oil. This brings us into another peripheral retinal disease, atrophic retinal holes. So here you can see a really large atrophic peripheral retinal hole. So remember that atrophic retinal holes have nothing to do with the vitreous. When we think about these, they happen usually during a routine exam. Patients are usually asymptomatic, and they're usually due to thinned out retina. So for that reason, we usually find them alongside lattice degeneration. So kind of some clinical pearls here that if you find an asymptomatic atrophic hole, they rarely need treatment. What the studies tell us is that laser may be considered if a patient is symptomatic. I always tell the students, if you have a symptomatic patient, always refer. Don't sit on it. If there's accompanying subretinal fluid, because remember that if there's fluid around the outskirts of the hole, that's an entrance way for more fluid to get in and separate the retina from the underlying RPE. And if the patient has a retinal detachment in the other eye, then they may be at risk for developing a retinal detachment in that eye. Also, always look at the anterior vitreous. Remember that looking for a Schaefer sign is an excellent in-clinic tool to assess for patients that may have a retinal detachment. If you have pigment in the vitreous, that's an indication that pigment has migrated off of the RPE through a break or an entranceway in the sensory retina. So you know that there's something bad going on there. The only time that doesn't work is in a patient that's had cataract surgery or some other intraocular surgery, because they could have pigment in the vitreous from something else. So just some treatments here, usually they'll put a barricade laser if they're concerned. If you have a young patient that has an intraocular lens and they haven't had a PVD, sclerobuckle is often used. And then things like vitrectomy can also be considered. This brings us to lattice. So here we can see a patient that has, lattice peripherally. There are some retinal holes within the lattice. Lattice is another one of those diseases, or I shouldn't say diseases, or conditions that happen from retinal thinning. That's why they go hand in hand. It happens in about 8% of the population. So remember, it's thinning of the retina. There could be some overlying vitreous liquefaction, but that's not part of the pathology. The pathology is really due to that retinal thinning. It's usually, they can be associated with atrophic retinal holes, tears, and retinal detachments. These patients are more prone to getting pathology in the peripheral retina. We know what they look like. They kind of look like fences or hatch marks. They could be pigmented, non-pigmented. There could be sclerotic vessels within, could be little areas of RP hyperplasia. We know the risk factors of peripheral retinal disease. Patients have blurred vision, flashing lights. This is all very easy. If patients present with symptoms, you should refer. Okay. Again, that's the clinical pearl. Symptomatic patients, we refer. And then I already spoke about the therapies, the treatments. And then the last thing I want to talk about is epiretinal membrane and vitreomacular traction, which truly I love because you really get to use OCT to diagnose these conditions. So epiretinal membrane really happens from an anomalous PVD. So the way to think about this is that we know that PVD is a natural aging process. Everybody gets a PVD as we age. But if the PVD isn't happening in a clean fashion, meaning it's taking too long or it's the vitreous is annoying the inner limiting membrane of the retina, some remnants may remain on the inner limiting membrane, and this leads to proliferation of the glial cells that live within the inner limiting membrane. So that's why an epiretinal membrane happens. The majority of the time, it's because of an anomalous PVD. Most of the time, they're idiopathic. Sometimes they could, meaning they're related to, something like an anomalous PVD. But if you get an ERM, they can also happen from vascular diseases, inflammation, trauma. So there are other etiologies, but most commonly it's from a PVD. Here's a really pretty picture of an epiretinal membrane that certainly could look like other things. So if you're ever not sure, is it an ERM or something else, get an OCT. Just some fun facts about epiretinal membranes. They are directly correlated with age. So when you're older than 50, you have about a 2% chance of getting an ERM. When you're older than 75, you have about a 20% chance. So the risk of developing ERM increases with age, and in any other person that's predisposed to getting ERM at an earlier age. So maybe, high myope, someone that's had intraocular surgery. In about 10 to 20% of cases, eyes that have ERM, let me move this, sorry. In about 10 to 20% of cases, both eyes can have epiretinal membranes, but they can be varying degrees of severity. Sorry, my mouse stopped working. This is another picture of an epiretinal membrane, but you can see here that there's something else going on. You can see that there's this kind of grayish area here hanging out above the retina. So hopefully you can tell that this is an epiretinal membrane with some vitreomacular traction. But let's say you saw this in clinic and you weren't 100% sure what you were seeing. Here's a perfect example of a time when you'd want to do OCT because you'll be able to see that vitreomacular traction. Remember that vitreomacular traction is defined as a tractional force within a 3 millimeter radius of the fovea. And it is categorized by an anatomical change. So when we're looking at, something like vitreomacular adhesion, where you might see the vitreous kind of touching or kissing the retina, it's not changing the anatomy of the retina. Here you can see that the vitreous is pulling the retina and causing a complete obscuration of the retinal anatomy. So that's how we would differentiate them. Oftentimes, vitreomacular traction and epiretinal membrane kind of come hands in hands because most of the time they're both related to anomalous PVDs. Risk factors. Those of us that are older Caucasian women or older women that are in the postmenopausal years are at an increased risk of developing VMT. And they believe that's because it has to do with declining estrogen levels that are protective as we age. Other risk factors, high myopes, having exudative or wet AMD, diabetic macular edema, retinal vein occlusions, and diabetic retinopathy. And really the reason is that these diseases interrupt the retinal anatomy. They make the adhesions or the connections between the retinal layers not as cohesive. And so if something begins to go awry and you don't have a strong network or a strong foundation, you're more likely to get disease states. Here's my heart-faced vitreomacular traction. Just some pointers on VMT. Remember that as I started off with AMD and said not all AMD is created equal, not all VMT is created equal. Remember to look at the width of the VMT. If you have a small separation, meaning from point A to point B, we call that focal VMT. These patients are more prone to developing macular holes than if they had broader VMT from, let's say, here to here. So looking at the area or the width of the VMT can help determine how you want to manage the patient. So this would be a patient that has an epiretinal membrane with focal VMT. Also keep in mind that the integrity of the photoreceptor line, the photoreceptor integrity line, makes a big difference in how you're going to manage the patient. So if the patient has a healthy photoreceptor integrity line, they likely are still going to have very good vision. If there's been a break from the traction in the photoreceptor integrity line, vision is likely going to be compromised. So here's a nice example of the top picture showing you vitreomacular adhesion, where you can see that there's been no change in the anatomy of the retina. As you move to the second picture, look at how subtle this vitreomacular traction is. You can see these little kind of pinpoint areas lifting up here. This is VMT. I would argue that both these patients are likely 20/20 because the photoreceptor integrity line is intact in both of them. In the last picture here, we also have a focal VMT with a few cystic spaces that have formed there. This patient also probably has very good vision because the photoreceptor line is intact. For management of either of these conditions, these are some clinical pearls. If you have an asymptomatic epiretinal membrane or VMT, meaning you find these on routine exam, you can monitor these by yourself. Okay, you don't need to be sending these patients out. Shorter intervals may be necessary, again, as I mentioned, if the patient has focal VMT, if they have a history of pathology in the other eye. But don't be referring all of these out, especially if the patient doesn't even know that they have them. This is something that you can certainly monitor on your own. If the patient becomes symptomatic, then certainly refer. Vitrectomy with a membrane peel is the gold standard. Pneumatic vitreolysis means they inject gas into the back of the eye, which makes a PVD happen. The reason we want to make a PVD happen is that if we can get that vitreous to detach, then it will release the vitreous traction. Other things to think about when referring. If a patient's vision is less than, and this number varies between 20/40 and 20/60 in the literature, but if the patient has decreased visual acuity, if they have metamorphopsia, if they have diplopia, if there's any evidence of progression, also remember to look at the contralateral eye. And I already talked about the treatment of choice. 80% of patients that have the diseases will improve by at least 2 lines if they have a vitrectomy and a membrane peel. So clinical pearls, VMT will, I think this is such a funny percentage because look at how broad this is. VMT will spontaneously resolve in 11 to 53% of cases. So even though that's a wide range, it shows how difficult it is to determine who is going to spontaneously release. That's the reason that, we want to watch these patients closely because a lot of them are going to just release on their own without any intervention. These are 2 cases of similar diagnoses with different outcomes. Pay attention to a couple of things. First, look at the width of the vitreomacular traction. Notice in the top picture, it's pretty close together. So it's a focal VMT. It's also a focal VMT on the bottom. The top one has some cystic spaces, so does the bottom. But if I were to ask you the question, which of these patients has a better visual prognosis, look at the photoreceptor integrity line. The patient on the top has a fairly intact photoreceptor integrity line. Patient on the bottom, it's broken. It's broken from here to here. Once that PIL is broken, there's really no way for it to regenerate. So the patient on top has a better visual outcome than the patient on the bottom. This is a tough call on which would you refer? Would you refer both? It's hard to say. Is patient symptomatic or are they asymptomatic? There's never a wrong time to refer, but remember to take into account, again, whether it's focal or broad, what does the photoreceptor integrity line look like? Think about all those things when you're trying to make a decision about whether to refer. And really the last thing here, just another case of VMT on the top. You can see the blue arrow is kind of pulling up there. The bottom one, similarly, these are both cases of broad VMT, but the inner retinal layers look pretty intact. The outer retinal layers, at least on the top, they're perfectly healthy. On the bottom, there might be a little bit of obscuration. So once again, use all the tools that we talked about to make a decision on how you want to manage these patients. So I think we're going to do a couple of fun things now. Do some quiz you guys. So Dr. Major, I don't know if you're around, if you want to jump back on.
Holy, excellent presentation, Dr. Rodman. Thank you so much.